So as you join, we are starting the session kindly, and please, I request each and every person who is joining the team, who is joining the session, to switch off their microphones, that is to mute, and also to switch off their cameras kindly. It's a request, and let's adhere to that. Thank you. Thank you. Thank you. Mary, what's the matter? Okay. So we're going to start our session for today. I'm going to introduce the panelists who are going to be there. We hope that we are going to have a good conversation moving forward. And from this session, every individual is going to be prepared for this, for whatever is happening. And if we have a case, we are going to have eliminated all the panics that are there. So today, last time we did an introduction part of it, part of the Ebola session. We also did infection control together with disaster management. So today it's going to be detailed and more detailed as we have panelists, Professor Njau, Professor Joseph Njau, who is going to talk to us on matters concerning pathophysiology of Ebola. Then we'll have Mr. Dan Were, who will give us the real case management from the experience and also with the compared to other diseases that he has dealt with in terms of infectious diseases. He's an infectious disease nurse specialist. We'll also have Mr. Christopher Kibiwot, who is a IPC, Infection Prevention Control Specialist, and also a disaster management officer. Then we'll have some remarks from a representative from Ministry of Health, that is Director Nursing Services from the Ministry of Health, Dr. Judith Awinja. I hope that we are going to have a good session and your questions are going to be answered. Your concerns are going to be responded to. And at the end of the session, we are all going to be ready. So just to introduce the platform, we are working with a platform on Let's Talk Nursing, which is a nursing platform that shares ideas between nurses across the globe, being led by our own Mr. Leonard Otieno, who is in. He will also give his remarks. And we welcome all other cadres who are present, because I'm very sure we invited different cadres in the session so that we be mixed and we share the information together. So at this juncture, I'll just introduce the session on Ebola, then Mr. Njau, Professor Njau will pick it up. So at the end of the session, we are going to provide CPD points. Let's Talk Nursing is accredited CPD point provider. So we are going to provide CPD points to all our participants. So be guided, and stay ready for the session. So Ebola virus, this is a viral hemorrhagic fever disease that has caused different outbreaks in West Africa, particularly in Congo, Guinea, Liberia, Sierra Leone, part of South Sudan, and currently we are aware of the issues that are going through the outbreak in Congo, DRC Congo, and Uganda. So we are dealing with a very new strain, Bundibujo virus, which is a strain that was initially found in Bundibujo, location in Uganda in 2007. And it's not well known how the strain is reacting and everything around it. The studies are still going on because it has a very low mortality rate compared to the other viruses that have come up with Ebola. So I'll welcome Professor Njau, Joseph Njau, to take us through the pathophysiology and just give us a recap on the whole Ebola virus, the origin, how it has gone, and now the real pathophysiology of how it acts, because its presentation and differential diagnosis is basically similar to other conditions. So Professor Njue, welcome. I'll give you the first 20 minutes so that you can give us whatever you have. Then I'll invite Mr. Were to give us the case management. Then Mr. Christopher will join. Then later we'll give a questions and answers session. So Professor, welcome.
Kind greetings to everyone on the Let's Talk Nursing Forum. Good evening all. Now, I will start off by discussing a little bit about inflammation and then digress now to the pathophysiology of Ebola. The reason I want to start with inflammation is because, and I will also dwell in pathophysiology, they're very, very interrelated. One is going to be a repetition of the other, is because when we talk about independent functioning of the nurse, it is actually looking at how the human body begins to become a problem to the person who is suffering, that the nurse steps in. And I like simplifying it by saying, if a diabetic person begins to feel sleepy, tired, and loss of energy and just lethargic, even a grandmother that administers porridge or even juice will treat that reaction. Therefore, a nurse can treat. One time I asked two medical consultants which two health professionals can make a primary decision in patient management. And then they started saying the doctor, and I told them that's not the question. The next one is the question. They started talking about laboratory people, started just juggling, and I told them they are lost. And I told them only the doctor or a clinician and the nurse. Why? The nurse treats pathophysiology of a disease, and the doctor treats the pathology. The nurse, in the work that was run, sometimes I think was it last year or the year before, about redefinition of nursing, in my perspective, I said, nursing is life maintenance by intervening to maintain homeostasis, because if you lose homeostasis, the patient will die. The body is designed to operate within a given chemical framework. If there's destabilization, which is loss of homeostasis, then the person dies. The body cells cannot function. So if the nurse now corrects, let's take example from COVID, because we are very familiar with it. When a patient was unable to breathe, and the nurse changes position into what we call pruning, whereby you make somebody lie down, lie towards the front, because the alveoli are many at the back. Therefore, you kind of widen the chest. The breathing got better, oxygen concentration improved. That is nursing treatment. So the nurse can manage and maintain life even without a doctor. And that's the most significant thing that I want to say. I know we have very little policy guidelines on independent functioning of the nurse. And I'm saying this because towards achieving this, we need to relook at a couple of things and see, yes, the nurse can do a lot of things. And as we're going to get into, almost any disease has some inflammatory process. So what is inflammation? Inflammation is a natural process of the body responding to an injury or an invasion or an attack of any kind by something that breaks the stability. I want to say both from outside and also from within, and it reacts by triggering immune modulators or immune uh, cells that communicate that there is need for the body to begin to preserve itself and to fight off invasions, called cytokines. Now, when the cytokines hit, they actually also cause the release of, like in the malaria, merozoites that would trigger fever, and they will also then cause some swelling of the particular part that is affected. It becomes very indurated, or redness happens because of much blood that jumps into that area and becomes locally hot. And because of all that reaction, the person begins to feel pain and unable to use the particular body part that has suffered inflammation. That is localized inflammation. Most of the times is acute. Think about a bee sting. The bee will sting a very small area. It's going to get swollen, it's going to get hot, and it will be painful. And even whoever it is not going to be able to use that particular part of the body because there is intense pain. And so there's loss of function. That's local inflammation. You can also have, and that's acute local inflammation. You can have attacks that cause widespread, not just localized. Think about a disease like colitis. Literally, mainly like the small intestines, and they're about 20 feet or slightly longer, they can all get inflamed right from wherever. And because of that, a lot of other activities will happen, like loose motion, painful, the entire abdomen is going to be feeling hot. You may not quite tell it's feeling but if you took temperature, like one time we were doing some activity and we were asking, which is the most sensitive temperature to detect? Like now we are screening patients at the points of entry. The most sensitive temperature would actually be the mesenteric temperature. But because it's not comfortable to expose people, then the next most sensitive is the carotid temperature. I was one time screening a guy who had come from Uganda and had participated in some work of trying to upgrade mortuary systems and used to work with Montezuma funeral homes. Then there was a guy, actually it was a colleague, because it was a radiographer had died, and then was discovered to have a Marburg disease. So when the pathologist was trying to come, because they found the abdomen swollen, instead of trying to aspirate first, cut it very carelessly, and they were spilled with blood, and they were not adequately protected. So when he came and we got the story, we were looking for him. Then he had picked up some sore throat somewhere, and his fever, when I took on the face, it was about 37, but the carotid temperature was 39 degrees centigrade. I'm trying to say this because the carotid carries a lot of blood, and the blood is a clear reflection of an inflammatory process because the temperature will be quite elevated. So that kind of thing happens. So at least I've talked a little bit what is this. And then we have also, and I've seen the sensory symptoms, but we also have another form of inflammation, which we call, before we get out of this, an inflammatory process can also become very exaggerated depending on the offending or invading organisms or foreign material. Assume somebody's become, like, let's say I was working on radiological injuries sometime. If you were exposed to, like during the Fukushima nuclear reactor that had a problem because of tsunami in Japan, you just walk through and get to the other side. Believe me, you literally be fallen down because of the heavy irradiation. And that's exactly what was happening with the Japanese soldiers. Just like also happened in Chernobyl in Russia, where it's actually that time it was the greater Russia. That part of Chernobyl was actually in part of Ukraine. Then you get down, that is massive. So what happens at that time is there is excessive cytokines, and it's referred to as a cytokine storm. a cytokine storm, then that will completely render the whole body completely non-functional, because this like the body completely migrates from routine existence to urgent self-preservation intervention. The body doesn't really want to die, but the body is struggling to make sure the local tissues begin to respond to the injury, bring in repair material and all those and that's called a cytokine storm. I've just remembered this because during 2009 H1N1 pandemic that people call a pandemic that was not, I came across a couple of very severely ill patients, and many of them that were perishing was because of cytokine storms. In both a severe inflammatory response and also some chronic inflammation. Now, in chronic, more often than not, you don't have an external invasion, but there is a change within the cellular or certain organ or tissues in the body. And that's what happens a lot when there is malignancy or tumors. Yes. Like some of this, if you have cysts, if some cysts break, the patient can go into anaphylaxis and actually can even die. That will be an example, a good example, where there'll be a cytokine storm trying to bring about some intervention to heal the body. So in that situation, the kind of reaction that happens causes the body to start injuring itself. In trying to preserve, they will amass every cell that looks, some phagocytosis or pinocytosis for the fluids that will be there. They tend to be engulfed and taken to the kidneys. The kidneys will get overwhelmed, and that's where you get some patients when they have an acute attack of whatever, they tend to go into a renal shutdown. Imagine patients who are invaded by massive bees attack, or even severe snake venom, severe envenomation. Then they tend to go into multiple organ failure syndrome. That is exactly what happens in some situations of inflammation. Now, because of my time factor, I just want to quickly now move in and talk about Ebola pathophysiology. Now, the reason that I'm just getting into this because immediately an Ebola virus, whichever strain, invades the body. And you'll notice that again, we said there are viruses that are not as severe. The Sudanese strain was one of the worst, and then followed by the Budibugyo. Reston virus that has at some time did cause outbreaks here and there. There is also another one called something Thai forest strain. Those were less severe than the South Sudanese and the Budibugyo. So now, assume somebody gets invaded by this through any mucous membrane. And again, I want to reiterate, either through droplet or actual contact. And in few documented cases, those have been excluded, but some people have also still been found with Ebola. So MSF sustains that people should use N95 mask when they are taking care of Ebola patients, because there is a remote, not well documented, but strongly suspected an airborne transmission can exist. And again, we've also known that a lot of patients, males who have Ebola, it tallies in the gonads for up to 3 months after they've recovered. They're still from their testicular tissue, they're still discharging Ebola virus. So therefore, for that kind of a situation, we are obligated to advise that they continue having assessment 3 months after, and if at the 3rd month you continue monitoring until there is no more discharge of Ebola virus. Again, also, it has also been found in vaginal fluids, but it does not last as long in vaginal fluids like it does stay in the testicular tissue. So when this invasion happens, it goes through the same inflammatory process that we've discussed. Now, because it tends to be the severe one, it quickly causes a hyperinflammation, which is as a result of a cytokine storm. Now, when there is this hyperinflammation, it tends to attack the neighboring vascular tissue, blood vessels, including the lymphatics everywhere, and it causes vascular leakage. Now, vascular leakage will be seen, and initially it's just fluids that ooze into a neighboring tissue, and people tend to begin to look like they are swollen all over. That you can see there are people whose eyes sometimes look, they are kind of like nephrotic syndrome. You see such scenarios. And apparently, remember, nephrotic syndrome sometimes is caused by pollen, poisonous pollen. Somebody breathed, they were working in the bush and whatever. So you find almost the whole system, the lungs, the eyes, the eyelids, and including some little brain edema is existing. So that does happen. So subsequently, it will trigger a coagulation disorder, because even the blood cells, they begin to get attacked, and in that process, some are breaking down, and the most attacked will be the thrombocytes. So you start having the coagulopathy more associated with bleeding rather than clotting. And because of that, you find that there will be blood is oozing. The endothelial tissue of the tunica intima of the blood vessels, the inner layer, begins to become porous. And so there is blood oozing to the neighboring tissue. You'll notice that in Ebola settings, you just take blood pressure, and when you remove the cuff, there is mark of blood. You put a tourniquet to draw blood. When you remove tourniquet, you begin to see color change. People with a lighter skin, it's much easier to see, and including people of the Caucasian origin, or rather with the white skin, you just see ecchymosis. In much darker people, you see some kind of extra darkness or some kind of purplish color. So that happens, and then it continues. Now, as that situation is happening at the vascular level, you find that it's spread literally across the whole body, and you have disseminated intravascular coagulopathy that will result in some petechial bleeding in the brain, in the lungs, in the heart, the liver itself, and the liver is rendered non-functional, also in the kidney. And remember, these are the 7 life support organ systems of the body, including the reticuloendothelial system, and then in the gastrointestinal system, then you find that patients develops bloating because there's no more good function. So when it continues like this, the patient is extremely very ill, and then they continue with more bleeding that becomes clearly overt. Any prick, bleeding does not stop. If people get some kind of heat, you see some swellings, which are basically hematomas across the whole body. And that's how now Ebola, or rather all other viral hemorrhagic fevers, will progress. And that is extremely very serious. I do not wish to look at many other things, but just mention that as this inflammatory process is continuing, and now critical organs are beginning to be get depleted oxygen supply, there is also excessive bleeding into their tissues, so they are no longer functioning. Remember, I said the inflammatory process, they will be swollen. They will there is breakdown of the muscular, the fiber, and therefore, like the heart that's supposed to pump blood, there is breakdown in coordination. How does it come about? You can imagine from the synaptic node, atrioventricular node, the Purkinje nerves, the cardiac muscle no longer can coordinate because it has a bit of blood clotting and dysfunction, including the nutritional supply, because the muscles will need glucose and also oxygenation. There is a bit of necrotic tissues developing here and there. So that then how happens that the whole body begins to fail to function. a Belgium definition of multiple organ dysfunction syndrome said when two or more of those essential organs that I just mentioned, 7 organ body systems, that's when they get 2 or more, then you diagnose multiple organ dysfunction syndrome. And usually it is a very, very ominous sign because it becomes very difficult to salvage or stop the progression because these organs depend on each other. When you have now a lot of red blood cells beginning to break down and the rest is bleeding, then sustaining life begins to become very threatening. When the endocrine system cannot be supplied with enough blood, oxygen, nutrients, the neurohormonal coordination begins to fail. And you will begin to see from the nervous system kind of small kind of paresis, and certain organs. Like imagine the diaphragm can no longer now function very well to breathe well, and it's coordinated right from the medulla oblongata. So you begin to have a person that needs real life support. And the situation is progressive, you may not be able to catch up with the speed to salvage the patient. So you can imagine, remember last time I said, I am very excited about nursing rounds. And therefore, as a nurse, like when you have a lead nurse, now guiding the other teams to modify the patient care every other moment because the condition rapidly continues changing. You focus on the observations you take and how you begin to respond. The better cases to deal with for that and to enjoy nursing would be possibly cancer. Because in cancer cases, you can actually halt the severity of cytokine storms by beginning to mitigate inflammation, either with drugs, which may be prescribed by a clinician, but even as a nurse, in certain jurisdictions, they're allowed to prescribe, but you can also offer foods that are anti-inflammatory. And one example that I had, we had during the 2009 H1N1, we had a secondary school girl from Kenya High. The consultant was completely unable to deal with this until the school nurse called me and I said, just ask for transport, go to the nearest chemist, buy vitamin C. And I told her, buy for 50 shillings only. And I said, give her as much as she wants to take. There's no overdose for vitamin C. In 6 hours, when the consultant came, now completely worried, what will be the outcome? Was told the girl has gone to school. She was now in class. She was already in school, but she was sleeping in the dormitory because she couldn't function. With severe inflammatory response syndrome, your body feels completely weak, prostrate, and you're able to function and you are just like feeling like life is jumping out. You cut this inflammatory response and you begin to recover and feel strong and better. That is exactly what happened to that Kenya High girl. The consultant came, said, I can't believe. She was said, let's go to class, you see her. The teacher was teaching. He said, Mwalimu, I'm here. I have to see this girl. And she was saying she was feeling better. And you know what she told the consultant? That she was given sweet by the school nurse. Of course, you know, vitamin C tastes well. Then they said, let's go. She called to say, I must go to school to see her, to understand how come I was able to treat. So a nurse can provide leadership in terms of independent functioning of the nurse. I come to the end of my part. I know I was supposed to finish at 2034 because I started about that time. I was given 20 minutes, now 2038. So if there will be questions, then I'll be still on and I will make a response. Thank you. I hope I have tried to make it brief, but talk a little bit about how does the physiological change happen to see the Ebola and how people get to excessive bleeding or die. And the other thing, I forgot, I need to mention, when this oozing comes out, electrolyte imbalance is another critical development that happens. And therefore, you find that like all of us here, we have a lot of ICU nurses, you know, with hypokalemia, you're going to start having cardiac arrhythmias. Without a bit of muscles, without a bit of magnesium and calcium, the patients may not be able to function. The certain muscles will have trouble because they need electrolytes are necessary for muscular contraction. So with all this, you can imagine how much the nurse needs to do. Remember, there's a story of one nurse who was asked, "How did you recover from Ebola?" She said her drug and drug of choice was ORS. Please, let's remember to monitor hydration and keep hydrating the patient, preferably with ORS. You can also add a little bit of energy by sugar, but as a nurse, you can advise yourself to keep monitoring the random blood sugar. Thank you very much, dear colleagues.
Thank you so much. Thank you so much, Prof, for the great presentation. I'm not letting you go for some few reasons. So in the session, kindly, if you have a question, just type it. I'll read it out so that it can be responded to. I'll request you all to mute everyone to mute and switch off your cameras. So there is a link that I've shared in the chat box. Kindly register for the CPDs. We'll provide CPDs at the end of the session. Kindly register for the CPDs. I would also like to recognize the presence of NCK, led by the NCK CEO, Dr. Lista Onsongo, in the team. So karibu sana daktari, and we are happy to have you here. For the questions, kindly just put them in the chat box. So Professor, before I leave you, let you and have the next presenter, I would just like to request you to explain the different strains of Ebola so that now our team can know that basically we are not dealing with the EVD, we are dealing with the BVD right now. So basically with also the fatality rate, where we have the Zaire, which basically with the data from WHO is showing about 65 to 90%. Then we have Sudan at 50 to 60%. Then we had Thai at 0%. Then now we're having Bundibujo virus at around 25% and low. The other virus the other Ebola that was there, which is Reston, has not caused any outbreak in the human beings, but it is good to explain to the audience so that now we can know the difference, and at least now when we are moving to the case management, we'll basically understand it much better. So kindly, Prof, just explain for us the different strains of Ebola so that we can understand it very well. Thank you.
Okay, thank you very much. By the way, the earliest Ebola virus that was detected was in 1961, and it was from Zaire. Then it kind of disappeared and nobody knew where it was hiding. Then the Sudan strain is the one that became now the most severe one. But however, the Sudan, the Zaire one had caused like 100% the mortality because there were very few cases at that particular time. There was even a doctor who was in DRC, Zaire, this was now Zaire at that time, and died in South Africa. Then the Sudanese one is one that was well documented and studied and was causing up to, actually was considered to be 80 to 90% case fatality. The Reston strain has never killed anybody. It's the one that has actually never killed anybody. And the outbreak happened because it infected only one guy. One guy is an outbreak, and it's associated with the Reston monkeys from Philippines. And they were being moved to America for some studies. And the guy who got infected was from Italy. I don't know whether the plane stopped there or the monkey needed some service. Then whatever, I don't know the details. But it was only that guy, but never died. But it was well tested. Then the Thai forest strain has caused mild outbreaks, and it's very low case fatality. Now the biggest problem is the East African strains, the Zaire one, the Sudan, and then the Budibujo is the latest that was discovered. So the last time I mentioned that the Sudan strain recorded the lowest case fatality after the Uganda outbreak, because there was already a lot of information. Uganda had a much better established healthcare system. And the reason why we see a lot of high case fatality in DRC is because the custom and the nature of the people of DRC is that they eat monkeys. Last time I remember telling you about this man who went and collected a monkey that was not completely dead, but was very, very frail, and was already having Ebola, and the wife was pregnant and carried it on his back, and then the wife was told, now slaughter it. And you know it's very good for babies growing inside. And then she developed fever. The whole, the obstetrician and the whole surgical team died. 42, it cost that one particular case cost death of 42 cases against very, very few people that had been affected. So the case fatality was seen very high, but it's because they had fed on an Ebola monkey. I think monkey or gorilla, whichever it is. So that is the situation. But the Uganda gave us a wonderful lesson that we can limit the deaths. I want to reiterate here, and please hear me and hear me good. And I'm not against anybody. This is the second Bujibujio strain. The first one happened after Uganda had just immediately discovered their oil. Now, the problem with us Kenyans, the politicians have taken over from health people, because some health people who should be talking have kept quiet. We still do not know whether the genetically, through a molecular characterization of the current virus, is similar to the first outbreak in Bujibujio. And that is significant because we know it had quite a bit of case fatality because people didn't know about it. In actual fact, it had failed to be tested because it was not responding to the primers of other non-Ebola situation, though clinically was presenting like an Ebola. So we needed to know, because possibly the current one has been manipulated in the lab with certain components of the old virus and whatever. And that therefore means health workers need to be alert. We know what happened with the nanotechnology vaccines of COVID, and we do not want to have a repeat of that. And therefore, we know that people who just got a jab and died. There are this German guy, old man, that was found a lot of nanoparticles, the spike proteins, completely overwhelming vital organs, and that's how he had died when they did a post-mortem. We do not want to get ourselves into an inadequately studied technology or nanotechnology in vaccines. Although there is much more advancement in nanotechnology, especially in the administration of insulin, that they have now been able to put like a sensor. The nano will only release insulin when the blood sugar goes high and remain like dormant when the blood sugar is low. But that was the first time the vaccine had been released. We want to understand and know what kind of questions can we ask so that we do not behave like we are. Remember the nursing oath that I will never take anything deleterious or harmful. No, when you cannot administer or take while you know that. So that is a critical component that all health workers, and particularly nurses that are on the lead, need to understand about the current virus. So thank you very much. I've explained a little bit what I can manage to do for now. Thank you, thank you, already.
Thank you so much. Thank you so much, Prof. At least you have really given us a good point. So basically, team, what you need to know is we have different strains of Ebola viruses. And basically, whatever we are dealing with right now, it's Bundibugyo virus, but which it has not been identified whether it's the virus that caused outbreak in 2007 or it's a different one. Because for us to know that the virus must be, they have to do a genomic sequencing so that now they know which specific species they are dealing with. So at this point, I'm going to welcome the next presenter. Keep your questions in the chat box, please. We'll ask all the questions and we'll respond to all of them. So our next presenter, basically, we are giving him the next session, which is Mr. Christopher Kibiwot, Infection Prevention Control Specialist and Disaster Management Officer He's going to dig deep into infection prevention and control matters and practices in regards to Ebola, because this is where the whole management of infection, controlling it, the outbreak lies with. So, Mr. Christopher, welcome. So, welcome to the session, and feel free to continue. Thank you.
Okay, thank you very much, Sylvester. As he has said, my name is Kibiwot. I work in Kenyatta National Hospital in the Infection Prevention and Control Department. I am a environmental health officer as well. Did disaster management, and I am a field epidemiologist. Maybe what I wanted to talk about today, because actually there was somebody who was supposed to handle the case management. What I just wanted to talk about was to try to marry disaster management, public health, and IPC. Let me start with a case study. Not a case study, actually. It is a real case which happened, I think, yesterday. A patient reported in a faith-based hospital in Nairobi. I don't want to say the name. So the patient had the epidemiological link, that is from DRC. It was a driver from DRC. Came with the classical symptoms of fever, general malaise, body aches, and some vomiting. So it could have fitted the suspected case divination. What did the faith-based hospital do? First, they called the Ministry of Health. And the guy at the Ministry of Health did not provide any direction. They just told the hospital, please transfer the patient to a management center, still in Nairobi. I don't want to mention which one, which is actually known to be managing such cases. They did not provide any ambulance. They did not provide any isolation. They did not take enough details of the patient. So guess what the patient used? The patient just took a Uber taxi to the hospital. At the hospital, they presented the same symptoms, plus, of course, the direction they were given by the Ministry of Health guy. And the patient was told, can you walk to IDU? I think you can see the gap. Prof, I am sure you can appreciate the gap there. What is happening about epidemiology is that there was a very big lapse. First of all, the incident command system, the one I talked about last time, the person at the Ministry of Health, if he was the one who is supposed to be the incident commander, he could have just told the hospital, do this, isolate that patient, as we send the experts to come and review the patient. And if there was any need for transfer to this treatment center, the patient should have gone with an ambulance, fully decontaminated, fully equipped nurses and the driver to take that patient to the hospital, the next center. And at that center, the patient should have actually been escorted by still well-equipped nurses to the IDU facility. Imagine how many, if the patient had the wet stage of Ebola, actually he was reported to be vomiting. So you can imagine how many people that Uber will carry in the course of the 24 hours. Very many. That driver of Uber will go home and actually will continue infecting others along the way. That patient, the so-called patient, would have infected, because I'm sure he did not come alone, he came with some relatives, and the relatives, nothing was recorded that this is the relative, this is the contact, this is the Uber they used. So imagine how bad we would be if that patient is Ebola positive. That is a lapse in public health. That is a lapse in epidemiology. And that is also a lapse in when we don't have a command center, a well-equipped and well-informed incident commander. We don't have that structure now. I'm glad that the people from the Nursing Council are there, and I think you have a representative from the Ministry of Health. Those are lapses which we actually do not want to happen again, and they might become what we call a disaster. So actually, there is a lot of gaps along the way. Despite the fact that we are saying we are prepared for this disease, I don't think that demonstrates the readiness that we want to have. How does Ebola become a disaster? Because at first, as I said last time, right now, it is an epidemic. It is a pandemic. If we don't manage that pandemic well, it will become a disaster. And if we don't manage that disaster well, it will eventually become a crisis where all the systems will fail and we'll just allow nature to take its course. And we don't want to get there. So what can make a disease like Ebola become a real disaster? I have what we can call a systemic or logistical hurdles, which I'm sure they are there in Kenya. We have the inadequate health infrastructure. So many rural health facilities lack basic utilities like running water and electricity. When I work as an IPC expert in KNH, we have gone to the rural hospitals and health centers. Even they don't have running water. Many of them don't have running water. Many of them don't even have a proper waste segregation facility. So we have inadequate health infrastructure as an enabler of making this Ebola become a disaster. We have resource and supply shortages. That is still part of the logistic. We lack facilities like isolation facilities. We lack beds. We lack linen. We lack body bags and all that. There is also a diagnostic delay, which is also a systemic and logistical hurdle. Before you get a sample from the far-flung health centers in the rural areas, it will take about 3 days before you get the results. And by that time, if the patient is moving freely, you could have infected other normal people. We have the funding and aid dependence. In Africa, we have had a lot of dependence on American and European aid organizations, to the extent that when America stopped providing us ARVs, there was a really big lapse. When they stopped providing us with anti-TB, the TB cases began to rise. So we have not been able to allocate enough funding to fight these pandemics like the Ebola. Then we have the geopolitical and environmental barriers. We know our regions are very porous. You can get a bus today and go all the way to DRC. There are some who walk from the forest in DRC to Uganda freely. And that's why we sometimes get a lot of cases in Uganda because of that mobility. There is a lot of cross-border mobility in coordination in Kenya. Then we have the sociocultural factors. There is a community mistrust and stigma because of political interference. You heard the other day that some people in DRC, just the way healthcare workers who are going to bury a body, and decided to take over the body and go and bury themselves. So that is mistrust which is in the community. Then we have the traditional practices, where if people are not explained well, they are likely to allow people to wash their dead and bury them. Then we have what we call the misinformation. You have seen what is happening in social media these days. A lot of misinformation. Somebody who has not gone to school just raising an alarm, and everybody else listens to it. And I am surprised that even the nurses, when you hear nurses talking about this Ebola, the way it is transmitted, the way it is going to kill millions of people, the way it is going to finish every one of us, I start wondering what's wrong with us. We are the ones who are supposed to be the voice of the truth, but we end up also being part of that system of misinformation. Then, of course, another thing which can make Ebola become a real disaster in a country is the human resource constraints. Right now, we have insufficient healthcare workforce, especially even the general, even to handle any disease, leave alone enough workforce to handle pandemics, enough workforce who are trained enough to handle serious infectious diseases like Ebola. Then what another lapse in the under the human resource is the worker safety and training. I talked to somebody who is in the border between Kenya and Tanzania, and he told me they don't have the protocols. They don't even know how to do the donning and doffing. They don't even have those PPE. They just have gloves. So that those are the challenges which can make a situation escalate from a pandemic to a real crisis, disaster. So maybe we can, Sylvester, you can handle a few questions, and maybe because I don't know whether Where is available, I can maybe I can chip in by coming up with the management of Ebola patients. Thank you.
Thank you so much. Thank you so much. So before you get in with the management of the Ebola, there is a place that is very, very keen when it comes to the Ebola management. Kindly, Christine Mudhoni, kindly mute. Kindly. Thank you. So there is a key place where it's very, very keen when you're handling Ebola patient. That is two main areas. So the point of waste management and the point of doffing. So what is your take? Because that is now the point whereby we normally do a lot of contamination, and it really needs to be talked much about. Kindly, Philip, kindly mute. Philip, kindly mute. Thank you. So Chris, kindly talk about the doffing point of it, and also waste management, because that is where the gap is.
Okay, thank you, Sylvester. By the way, the areas where we are likely to get that contamination as healthcare workers are the ones Sylvester has tried to point out. How do we segregate our waste, or how do we manage our waste from the point of production to the final point of disposal? Number two is not necessarily during the donning, it is during the doffing. These are the areas where the risk of transmission is the highest. So let me start with the waste management. The waste management in Ebola situation or any infectious disease condition is very crucial as an IPC measure, not only a public health measure. Remember, public health is a link between the hospital and the community. IPC is actually what is the link between one clinical person to the next and the patient. Actually, IPC happens mostly within the hospital. That is why it is infection prevention and control. Where we get the link to the public health is that we are dealing with a patient and a relative who might go back home. So that is where public health should actually take over. That's why when we talk about case finding and tracing, that is public health. For IPC, so when you will manage a patient in an ITU unit or a patient who is suspected to be having Ebola, waste segregation at the source is very important, because remember, Ebola is by contact. Contact means wherever you touch with those dirty gloves is a potential source of that virus to the next person. So wherever you dispose the dirty glove, is also a potential risk to the next person, including the cleaner. Wherever you put that linen, or the way you dispose the linen, is also another weak point. So we say in an Ebola situation, when we go into that room, we perform all the duties at once, and every waste should go to the correct place. If it is a sharp, it should go to a sharp container. And actually when we talk about the sharp, it is the needle plus the syringe going into that bucket until it is 3/4 full when it is locked. And after that, it is given priority. When it goes for incineration immediately. Number two, when we talk of the clinical waste, it is all supposed to be in red. In IDU, we always use red so that Red informs the person doing the incineration and informs anybody who is handling that waste to handle with care. That is why it is supposed to be put in red. Number 3, after you are done with putting the waste into those liner bags, red liner bags, you are supposed to make that the round tie, the what we call the gooseneck knot. That is, you just rotate it around, then tie it, and it is supposed to be decontaminated with sodium hypochlorite or the appropriate chemical, so that the next person handling will be a bit safe, although they will also be in a PPE, and it is given priority as well. So anything which comes from an IDO unit or an isolation facility should be given priority when it comes to incineration or the final destruction. If we are supposed to use any transport to the incineration center or to the final disposal center, that vehicle should be closed. It should have somebody to spray before we load, and we should have somebody to spray after we unload. And all the PPE which the people are wearing should also be incinerated along. So for healthcare workers, especially the nurses, we should be very careful on how we dispose the waste we generate. Actually, the generators of waste are mostly the healthcare workers, not the support staff, not the relatives. It is the healthcare workers. So that waste should be handled very carefully, given the appropriate priority when it comes to final disposal. And it's in ideal situations, an IDU should have its own waste segregation, and waste destruction port nearby, not necessarily taking them 1 mile away so that it mixes with other waste. So for the linen, that is where I need to talk about it here clearly. Linen from Ebola patient are not soaked in sodium hypochlorite, as I saw somewhere. You just remove the linen very well, as with all your PPE, appropriate PPE. Fold it nice, not folding, actually roll it nicely. Put it in a red liner bag and just tie the same liner bag using the same knot that I talked about. Let it be sprayed by the public health officer with the appropriate decontaminant. And sodium hypochlorite is said to be still very, very much effective against the Ebola virus. Let it be sprayed before it is taken for processing. The ideal situation should be we use disposable, but in our case, we are not capable to do that. But when we take it to the laundry, the process of laundry will make sure that that Ebola is actually killed within the shortest time possible. What is recommended, and actually we have brought that forward very clearly. We need to have those liner bags which disintegrate when it is put in water. So that way, there is no exposure of the laundry person trying to untie or cut the red liner bags so that he extracts the linen. So we just want somebody to throw the entire bag with linen into the washing machine so that it disintegrates later. So that is about the waste management, very crucial. Then when it comes to doffing, this is where the other problem is. During doffing, as I said during the last presentation, you are not supposed to perform the doffing alone. Remember, during that time, you have been in the IDU nursing patients for the last 1 hour or so, or even more than 1 hour. By the time you come to doff, you are tired, the mind is not coordinating very well. In the doffing area, please, you try to follow the instructions of the person telling you, now remove the gown, now remove the goggles, and now remove one step by step, so that we don't make any mistake. When it comes to the full PPE, we have 2 crucial areas which tend to be prone to contamination. Number 1 is the zip. And to mitigate the zip, that is why we put on the plastic apron after we have done the donning. Then we have the other weak point is the sleeve between the glove and the full coverall. So that is an area we are not supposed to be touching anyhowly with any contaminated glove. So that is why it is very crucial. I can see somebody has put the video there. So when it comes to doffing, that is where the mistake happens. You are supposed to do it as buddies, because you enter in as buddies, and you follow the instructions of the person giving you 1, 2, 3 steps of what to do from the beginning to the end. After that, you are supposed to perform thorough hand hygiene. You remove the boots that you are having after going through the bath, a foot bath, and from there you are free to join to go and have your tea or something like that. So anyway, that is briefly how we are supposed to avoid contaminating the environment or contaminating other healthcare workers during doffing and during waste segregation. Back to you, Sylvester.
Thank you so much. Thank you so much, Mr. Chris, for the great presentation. At least now we are now aware of where we are heading to, and keep on asking questions in the chat box. Keep on asking questions, because I know you have a lot of questions concerning that. I still request each and every person to mute their mic, please. Kindly mute your mic. Thank you so much. Kindly mute your mic. So as you ask your questions, I'm going to bring the next presenter, Mr. Dan Were, who is an infectious disease nurse specialist. He has really worked with the West Africa team and currently leading the Ebola team. He'll tell you where. I want to welcome him so that now he can give us a case presentation. So this video, basically, we'll play it later so that now we can hear what Mr. Were has for us, so that you can know what is happening with the donning and doffing. So Mr. Dan Were, welcome to the session, kindly. Mr. Dan, kindly give us the case management of a BVD patient or a EVD patient, kindly.
Hello. Are you able to get me?
Yes, you're clear.
I'm clear.
Thank you. Yes.
Yes. Good evening, everyone. My name is Daniel Were. I work at Kenyatta National Hospital as a nursing officer in the infectious diseases unit. My background has been in the infection prevention and control practice, and I'm one of the nurses who participated in the 2014 Ebola response. And so I gained a lot of knowledge and experience in terms of care and also management of Ebola patients. So currently I am again very much involved in the preparedness in the event that we get a case of Ebola, or just to give also the public health, the public education on the preventive measures that needs to be taken so that we don't allow the disease to get into our country. Now, I must apologize that I left work late, and so I was not able to follow on the earlier presenters, and so I may also need much of your guidance, Mr. Sylvester, on the key areas that you'd want me to talk about, because I know most of the presenters have touched almost everything in terms of case management and even the IPC, as I see on the screen.
Yeah, so Mr. Were, thank you. So we have tackled on pathophysiology of the Ebola disease. We have also gone ahead and talked about different
You
strains.
prevent. You unajiprotect.
Kindly, Shaila, kindly mute.
Huwa tuliishi na watu wa COVID.
Okay. Kindly, if you join mute. So, Mr. Were, sorry, we have talked about pathophysiology of the Ebola virus, and also we have talked about different strains of Ebola, which was being presented by Professor Njau. Then Mr. Christopher talked about infection control. He also talked about matters of public health, also in relation to the disaster management. So in your case now, you're coming in as the real management now of this patient. We have found a patient who has Ebola. So what are some of the things that we need to do inside that room so that we have this patient back to his or her feet? So that is where we really need you.
Okay, thank you very much, Sylvester, for that background information that you've now given me. Now, one thing that I want to say that in West Africa, what really brought in the success was the introduction of IPC, because in 2014, IPC was not very much pronounced, but that was the silver bullet that stopped the spread of the disease and also stopped the death related to Ebola. So again, that one thing that all of us need to understand is that early diagnosis will always bring a recovery, or will also increase the survival rate among the patients or people who contract the disease. And so, and then this is not just a word that is said, but that is the truth. That once it is diagnosed early, then it means the recovery rate will also be high, because Ebola management is just is conservative or supportive management, whereby you handle the symptoms as they appear, and then again you also prevent any other secondary infection that may occur. But the only challenging part that we have for this strain that is currently in the Democratic Republic of Congo and Uganda is that there's no known cure for it or of the vaccine. But the one in West Africa, they were able to get some, we call it what, monoclonal, that kind of antibodies they were using. And then again, later on, the vaccines came in the midst of the pandemic. And so here, when the Ebola on the signs and symptoms that we all know, most they will go in phases. There's the acute phase when the symptoms are pronounced, and then there are also the late signs that will also show the direction of the direction that the management will take. Again, some other late features may also show that some organs like the liver and kidneys are involved, and when those two organs are involved, those are now the times when you will see a patient presenting with bleeding. And when and those are the kind of stages that most of these patients, they are likely to die because of the organ failure. And so, as we have said, is that early detection is very key. And so when there is that kind of health awareness in terms of public awareness, where people are able to detect and then report the cases, then it will always be easier to manage than when these cases are not reported or people go to seek alternative medicine. And so I want also to give some kind of information that in West Africa, what also helped a lot in improving the survival for many is that despite the medication or the treatment care that they were giving, that they were getting, you find that again in terms of managing, in terms of nursing care and the other basic needs of the patient, some of the survivors were used to help in or to assist in giving this kind of care, because it was realized that these people who survived or the ones who recovered from Ebola, especially the female patients, they developed immunity that there were no cases of reinfection, and so they easily came in handy when it comes to maybe feeding of this of these patients, so that the nutritional support was maintained, as even as some of the medications that may also the urgent medication that would require to be given to the patients, and also to limit the exposure of the healthcare workers. So these are the people who came in handy to also reduce the exposure. And because one thing is that this is contact transmission, and the much there is that kind of contact, that is how the risk of the risk of infection is increased. And so those are some of the key factors that would be required even in the current outbreak, that there is limited exposure even from the medical personnel who attend to these patients. And so all the management of these patients need to be scheduled in such a way that the frequency of getting into the patient care areas is limited, and it is well scheduled, such that different staffs or different health personnel go in at specified times. I think up to that, maybe if there is any part that is not clear, we can have someone to, you can ask a question or it can be clarified. Hello, are we together?
Yes, we are together.
Yes, we are here.
Okay. Yes, up to where we have reached. I don't know if there is any clarification that may be needed.
So the only thing I can request Mr. Were to talk about is if we, in the management now, you have the patient inside the isolation unit.
Mm-hmm.
So what are some of the main things that you were doing to the patient that really you can really say that was most of the priorities when you had the patient inside?
Right. When, as I have said, that the management is symptomatic, or it is conservative management, that you manage this patient according to the way they present, and so there is no specific cure for most of the viral infections. And so Ebola is also a viral infection. And then so again, one thing that will be done to this patient is just to ensure that all the necessary needs of the patient is addressed. And I have said that the management will always depend on the stage that the patient has been, or that the patient has been identified and admitted in a treatment unit. And so the other things will just be done according to the clinic, just like any other medical treatment that the patient would get. Yeah, and also the nursing care will always just be the same. If the patient is not would require total nursing care, then the management will just be like any other patient, as long as the healthcare personnel ensures that they are well protected in terms of the PPEs that they are wearing. Yeah.
Oh, thank you so much, Mr. Were. That's a great one. Actually, everyone, at least you have a view of what happens inside that isolation room. So before we go to the questions and answer session, I'll bring back Mr. Kibiwot, who will explain the flow of the unit, of the isolation unit, because now we have 3 different cases and how those patients are supposed to be placed. We have suspect, we have probable, and we have confirmed cases, how the flow of that unit is supposed to be. And also, he will also talk about body handling, because at the body handling, when a person dies, that is when now we really see a lot of fluids coming out, and that is when we have a Ebola virus. We know that is at that stage is where we have a lot of infection, and if we don't handle that body very well, we may end up having a lot of infection. So, Mr. Kibiwot, are you ready to come back?
Yes, I think I'm ready, but let me set up the slides.
Okay. Meanwhile, Let's Talk Nursing is a platform that offering a place for all nurses globally to air their views and also to share information. We are a CPD accredited association, basically dealing with healthcare, nursing workforce. We empower nursing fraternity, and we are very happy to be here with our regulators also, Nursing Council of Kenya, represented in the team. And we also have different unions and different associations here. So basically, being that we are here for each other, we are going to respond to all the questions. We are going to be there for each other. We are offer mentorship also sessions to different individuals, different institutions. Feel free to ask your questions. Feel free to be part of the team. And as we move on, we are going to know what we are going to do. So Mr. Kibiwot is setting up his slides. Then he will come in with the final session as we ask questions. Mr. Christopher, are you ready?
Maybe I can
allow me to share the screen.
Okay.
Okay. As Mr. Sylvester and Mr. Christopher is preparing, maybe
yes,
we have a link at the chat box. Please register for CPD points.
Yes, kindly. There is a link for registration for CPD. Kindly register with that link so that we can have your details and share with you CPD points at the end of this session. Kindly register. Remember, the platform is not just for the nursing session training, but we also welcome all individuals who are interested. Both we are here with doctors, we are here with lab technicians, we are here with pharmacists, we are here with public health officers. So we welcome each and every individual in our session. So feel free, feel welcome, ask as many questions as possible, because we have the experts in the team. So thank you so much, and welcome, Mr. Chris, so that you can talk on the 3 sessions that you have. Thank you.
I hope you can be able to see my screen.
Yes, just place in a slideshow, please.
Okay. Slideshow.
Okay. Okay, Sylvester, can you be able to? I'm unable to get into the slideshow. Let me see.
Yes, you're just there, down.
Down here.
The cursor down on the near the Zoom and the Zoom area.
Okay, I'm seeing this. Okay, I don't know.
You see where the zooming is?
Yes.
Yes. Now next there is something like a television. Just click on it.
My cursor is refusing to to click it. Anyway.
Okay. Just Mr. Chris, you can just proceed.
Okay. Wow. Wait, can you do it from your end? Because it's not moving here.
Let me share it. Let me just share the slides for you. Okay, you can proceed, Mr. Chris.
Have you loaded Sylvester? No, I can't see.
Yes, it's there.
Wow.
We are not able to see it, Sylvester.
You are not able to see?
Able to see, yeah.
Okay. Able to see it now?
Yes. So we can be able to see now. So let us go down, because I will not be going through what Prof has talked about. I'm not going to do also what Mr. Wera has talked about. We have talked about differential diagnosis, triage, IPC, how we do the investigation. Screening and triage. Remember what I talked to you about that case. Everything failed there during the screening and all that. So I'm going to talk about the PP, particularly the donning and doffing. So Sylvester, let us start with the donning, because that is actually a matter of life and death situation. Because remember, we talked about the controls, about elimination and all that. What we are remained with, what we are left with as healthcare workers is the PPE. So you must have the correct way of wearing the PPE. And because at the end of the day, at your far-flung health facility, you might come across a patient with Ebola, and you are on duty, and you are the one to step in to try to do the donning and doffing later. So it will be actually very difficult for you to run away from that. So we better prepare ourselves for such a scenario. That is about the donning. So when it comes to donning, we start by making sure that we are ready. You have to be mentally ready and physically ready to do the donning as a healthcare worker. You have to be very comfortable. Do not have any full bowel. Do not have any full bladder. Be well hydrated and be in a good health so that you can be able to withstand the full body suit for the next 2 or 3 hours while standing and doing procedures. That is a very important part. Remove watches. remove bracelets, leave your phone at the desk. You can switch it off and leave it with the person at the desk. Usually, the isolation unit has a one-way system. You enter from point A and you exit from point B. So you don in point A and you doff in point B. There is no going back and forth. Then when you are prepared, perform your hand hygiene, then select your PPE. Select the size of your full body suit or the hazmat suit, the way they sell them. Usually they come in a full package where we have the full hazmat suit, we have the goggles, we have the N95 mask, and sometimes we have the clinical or what we call surgical gloves. Make sure you have the correct size. If you have too large, you are going to be clumsy when you are doing your procedures and you can easily contaminate yourself. If it is too small, the PPE or that full hazmat suit can rip apart when you are doing the procedures. So you have to assess, make sure you have the correct size. After performing the hand hygiene, we usually start with the boots. And the boots are usually available and they are supposed to be as sterile as possible. If not as sterile as possible, should be as clean as possible. To have been decontaminated and all that. And they must be only for use in that treatment facility as well as said. You put on your boots. Inside again, make sure you have your easy scrubs, which should be made of cotton so that it can be able to absorb any sweat that can come out from your body. Don't put on something which is nylonish, which will make you sweat excessively. The first thing to put on is usually the full bodysuit. And you have your boots, gum boots already, or the footwear. The hazmat that we have is usually covered from the toes all the way to the head. So you put on one leg first and the other leg second. Then after that, pull it up, insert your two hands and let it just go freely. Then and don't flip the hood first. After that, with one stroke, put on the zip. By the way, I missed a step. You put on there is what we call the first glove before actually you start putting on the overall. And let me point here that the first glove, which is supposed to be the one which goes all the way to almost the elbow, is the one which is supposed to be like your hand during the entire process. That one never comes out. What you will be changing is your second or the third glove only. So the first glove will remain with you all the way until you are done with the procedures. So that is very crucial. Then you put on, slip on your hands comfortably, then you zip. Make sure you see that the sleeve of the hazmat suits, some come with a loop already put in place where you can insert your thumb. Why is that important? Because I said earlier, the vulnerable point where you can be able to contaminate yourself is between the glove and the sleeve of the hazmat suit. So you must have that loop. If the loop is not there, make sure you rip a little space so that your thumb can get in. That is very crucial. That makes sure that hazmat suit, the sleeve does not go up in whatever circumstance. Then you can now put on your mask, and the mask recommended is usually the N95 mask with a valve, although sometimes they supply the ones which do not have a valve, but you just put on that N95 mask. And the way of putting it on, you should start, take your left hand, tap that mask comfortably and apply it on your nose and mouth. It has to cover the nose and the mouth very comfortably. With the other hand, the right hand, slip down the lower strap, which has to go below the ear, and then slip on the second strap, which has to go above the ear. Please do not crisscross those straps, because when you crisscross, you leave a gap close to your ear, and we don't want that gap there. Then after that, there is usually an aluminum clip at the nose area. So make sure you adjust that clip so that it fits into your mouth and nose very well. Then you do what we call the testing. When you have to breathe in and it has to collapse. If that mask does not collapse, it means it's not airtight. So you have to do that test before you say you have done your job well. Then you put on your goggles or the face shield. The face shield, you just put, usually it comes with one strap. So you just put it on in one move, and they're usually elastic straps. So you just put it behind your head comfortably. But remember, now this is where the importance of that clip comes in. And please, you listen carefully, because if you have not put that clip properly on your nose, when you go in there, the exhaled air will go into the face shield or the goggle and will make you blind in that Ebola unit, or it will make you blind. You are not even able to see what you are doing. So that is important to make sure that you clip that nose very well so that there is no moisture getting into the face shield or the goggles. Then after that, you flip your hood. Once you flip your hood, you are done with the hazmat suit. Then the next is because I said there are two vulnerable areas: the sleeve between the glove and the hazmat suit, and the zip. That is where another risk is. So to mitigate that risk of the zip, you put on a plastic apron, just as a final measure. Then from there, you can put on your second pair of gloves. Your second pair of gloves will be the one you will be changing from time to time. You do a procedure, you remove and dispose it in the clinical waste. In our case, it is going to be a liner bag in a red bin. So that second glove is the one you will be interchanging. You do bed making, you throw it away, you put on a new one, exactly like that. You do treatment, that is the one you will be changing. The first one you put, as I said, I repeat, is supposed to remain with you until the end. That is like your skin. Then, after you have done that, you have put on your second pair of gloves. You have a buddy, where I said, when we go to that clinical unit, don't go alone. You are supposed to go there, at least two of you. Two of you have to assess each other, make sure that every place is protected. There is a mirror usually in that donning area. Also be satisfied. Look at the mirror and see that your face is well covered. There is no misting. Your hazmat suit is well fitting. There is no problem about that. Then at the back, usually there must be somebody who is supposed to be supervising you during the donning. That person does not enter the hazard area. So you'll write your name at the back. The importance of the name is for identification purposes. Number two, in case anything happens in that treatment facility, they will be able to know this person was so and so. After that, you are free to go and take care of your patient. And actually, when you are treated like this, there's nothing to fear, because even if blood comes into contact with you, you are very safe. And remember, inside the patient room, we have the sodium hypochlorite, 0.5% for surfaces. Surfaces includes your gloves. Every time before you remove the outer glove, which is working glove, you are supposed to do what? To decontaminate using sodium hypochlorite. Perform antigen using sodium hypochlorite before disposing it. That minimizes the virus load around your glove. So you are ready now to go inside. And I need to emphasize here that in this case, there is no doctor, there is no nurse, there is no consultant. When you go there as a team of maybe 3-4 people, you are going to do all the procedures that need to be done, because we want to minimize the number of people going in and out of that treatment area for as much as possible. So when you go there as 4 people, you will draw samples, you will do bed making, you will do feeding, you will provide treatment as a team, so that for the next 2 hours, nobody will be entering that isolation facility unless there is need to be doing procedures every 30 minutes or 1 hour. But remember, you're always supposed to be working at least 2 people. Then you do your procedures from first bed to the last. And usually the way your patients are placed in the treatment area is that we start with the cleaner as you finish with the dirty patients. Now, after you have done with your procedures of treatment and all that, now it is time to do what? To do the doffing. And I said another critical area where contamination can happen is during the doffing. So Sylvester, you can put the doffing slide. So you are done everything in your treatment facility. Maybe you have finished 1 hour, 2 hours, or 30 minutes. We always say, take as short time as possible in that hazardous environment. So usually you come, they usually a red line between the hazardous area and the clean area. And your supervisor who had actually supervised you when you are going in will be standing at the exit. You'll be having also a public health officer with a knapsack sprayer ready to do what? To spray you and to make sure that there is zero virus coming in from the treatment center. So here you perform glove disinfection of the outer glove. Remember, always you have been wearing 2 pairs of gloves. The one which is like your skin and the outer glove. So you perform disinfection of the outer glove with sodium hypochlorite 0.5%. Second thing to do, you break. Remember the one which was covering your hazmat suit, the plastic apron. That is the first one to come out. What we usually say, right now, the dirtiest or the most contaminated item comes out first. So the most contaminated part in this case will be our gown. So that is the first to come out, and you use 1 loop movement. You just break it from the least contaminated area, which is the back of your, below, above your shoulder. Break it, and then roll it forward, and then dispose it in the red liner bag which is provided. Then perform hand hygiene, glove hygiene. Oh, okay, it's hand hygiene still with ABH, with actually sodium hypochlorite. Now this is the time to remove. Remember, the most contaminated item there will be the gown and your outer glove. So you have removed the gown. And usually that gown is removed after the public health guy sprays, usually below the umbilical area, below the navel area, because actually when you are working, the most contaminated part of your body is actually at the bed level. Then, after removing the outer pair of glove, perform hand hygiene now in the inner glove. That is when now you start removing the hazmat suit. How do you do that? You flip with 1 movement, flip back your hood. Once you have done that, unzip with 1 move again, unzip the hazmat suit all the way to the waist area. Then you start removing, making sure that you remove, if you want to touch anywhere, always touch the inner part of that hazmat suit, never the outer part, because the outer part is a potentially contaminated, but inside part is okay. So you can remove with 1 hand first, remove the other hand, then touching inside of your suit. So push the hazmat suit to the below the knee level and over your boots. Then you wriggle out slowly by slowly until it comes off. When it comes off, touch the inner part as you roll it. The inner part, roll your hazmat suit from inside, then dispose at the red liner bin available. The next to come out is the goggles or the eye shield. After performing hand hygiene, remember by now you have the only glove which is acting like your hand. So remove the face shield or the goggles using one sweep motion. If it is supposed to be reused, put it in the correct solution for sterilization. Usually, the goggle is the least contaminated, especially when the procedures you are doing generating a lot of aerosols. Then after that, you now remove your N95 mask after performing another hand hygiene. After that, you can now remove your inner glove. Remember, you are now free already. Whatever you have in your body now is just your scrubs. You have the gumboots, which are still as clean as possible. Now you remove your inner gloves. Then, with one move, cross the red line, come into the clean side, where you'll find a foot bath with sodium hypochlorite or the appropriate solution, so that your boots are also decontaminated. Then after that, you can go and perform your hand hygiene. You can put on your normal mask, or you can go and have tea somewhere. And that process will be supervised by your supervisor to make sure that you have not made any mistake which can contaminate you. I think that is how it should be when it comes to donning and doffing. And as I said, you should be more careful during the doffing area. I also need to talk about the specimen collection. This one is usually done by the phlebotomist, who should wear full PPE. Remember the team I talked about, which can go there, about 4 or 5 of them. The phlebotomist will also be part of it. They're usually trained in handling such hazardous material. They will be using the external glove to do the puncture. As soon as they have done the puncture and drawn the blood, they need to change the gloves before they handle the clean bottle and do any labeling, if there is any labeling to be done. And if it is supposed to be done with a marker pen or a pen, that pen should remain in that, should be disposed as an hazardous material in the same red liner bag. Then usually it entails what we call a triple package system, where we have the primary container, the one for collecting the blood, which is put into the next container and zip locked. And that container, as soon as you do that, you are supposed to change the glass again. Kirumba, just mute, please. Then after that, you put it in the third and final transport package, and it is ready to be taken to a level 4 biosafety laboratory. We have one in, I think, in Cambridge, and we have another one in Kisumu, in Kenya, if I'm not wrong. Maybe Prof can confirm that. So that is about specimen collection. It should be done by a trained phlebotomist. Don't go there as a nurse and you are told to get a sample. Don't go there as a doctor who is not trained and told to take the sample. So the third part I need to talk about is maybe body handling. This is also very crucial because you might be called upon in the peripheral facilities that there is somebody who could have died from Ebola, and you are needed to give an advice. This is very crucial, by the way, because we are the ones at the end of the day who should be responding. So there should be 0 direct contact. Only trained mortuary personnel on full body PPE are permitted to handle. All the invasives, including granulas, invasives such as nasogastric tube, invasives like urinary catheters are never removed because we don't want to increase the risk of the virus in the environment. Leave medical devices in the patient. Remember, Ebola bodies have the high viral load, hence IPC measures must be adhered to. So you put that body in a body bag, which should be watertight. And after that, after zipping, it has to be decontaminated thoroughly, and it is supposed to be taken for burial immediately. No body viewing, nothing like body handling again. So the body is wrapped with heavy-duty leak-proof plastic body bag. It is sprayed with sodium hypochlorite 0.5%, The body bag is labeled. And as I said, whatever you use, if it is a pen, if it is a marker pen, it should be disposed appropriately. So it should never be opened. And family engagement is very important here. Engage the family respectfully. Inform them that this is a highly hazardous body, which must be buried immediately and by the experts. So that is how you can actually bring in compliance. Another very crucial part, because the people from the Ministry of Health and the Nursing Council are here, is how do we staff an infectious disease unit? All staff in an IDU must be qualified professionally. Qualified professionally means you are either a doctor or you are a nurse or a public health officer. You must be appropriately qualified professionally to handle issues. Additional experience in clinical setting is very important, because you cannot bring somebody who has never been in a ward and tell them to manage Ebola. They will not know where to start and where to end. They must be trained or retrained on handling highly infectious diseases, focusing on the current threat, like now the Ebola. So this can be achieved through CME's demonstration, and what we are talking about now, it is still a CME and training, so that if you are called upon, at least you have an idea of what you need to do. So the number of staff operating in an IDU must be adequate in number, at a ratio of 4 patients per doctor and 2 patients per nurse. And as I said, we work in teams. Working clinical teams must be paired with a supervisor in a clean area. This is very crucial, because we don't want anybody to get tired while working. There should be at least 2 teams who work for a specified period of time. So, like in an Ebola center, we have 2 teams of 10 nurses. They work for 3 days, and the other group of 10 nurses are resting for the 3 days. When these 3 people, the first team finishes, the other team takes over. It can be a 1 week. You can increase the teams into 3 if you want people to rest for a longer period of time. When the second team takes over, the first team take a break for the same period. If it is 1 week on, then they will go 1 week off. During the break, each team will be on self-observation period, where if they notice any symptoms, they should report to the facility for checkups immediately. We are not saying we quarantine the people working in the Ebola treatment facility. Why? Because we assume that everybody was wearing PPE correctly. Everybody had followed IPC measures to the letter. So we don't need to quarantine you, or we don't need to isolate you. And remember, you're working as a team. If you notice that your team member possibly removed their PPE inappropriately, that is a person you should recommend to take a certain break. That's why hospitals should provide facilities for a nurse who feels that they have been exposed to stay there for about 7 days to 14 days for observation. So members of each team will divide themselves into day and night shifts according to how the numbers prevail. If a longer off is needed, you can have as many as 4 teams, so that when you work for 1 week, you can rest for 20 days. So that is how we should actually be able to staff an Ebola center. So if need be, the hospital can organize comfortable accommodation to staff who feel they do not need to go home. Their people will be fearing to go and join their families. So the hospital should provide such facilities. And it should not be mandatory for somebody to be quarantined because they have managed a cholera, an Ebola patient. The hospital should provide meals and allowances to the IDU staff. Those are the motivators. You cannot expect somebody to come and stand in an IDU for 8 hours. Then they don't even get tea. They don't get even lunch. Then we need that additional motivation. If it is 1,000 as a token per day or 2,000 per day for the entire period of when they are on duty. So a team should comprise of at least 2 doctors. That team I've talked about, a team of 10 or whichever number we may deem necessary depending on the number of patients. 2 doctors, at least 8 nurses, 4 support staff, 2 public health personnel, one messenger, and a dedicated laboratory technologist, and a head nurse who will be doing the supervising and ordering the supplies and all that. So I think that is very crucial when it comes to staffing. The question is, are we prepared for that as a country? That is a question I leave to the experts. We do not. I don't know whether we are at that level. This is a demonstration of a Ebola training facility. You can see the clean zone and the dirty zone. In fact, an IPC team, whenever a center has been established, an IPC team is supposed to go and do mapping and remapping to make sure that we have a very good flow of patients and flow of staff. Yeah, I think that's what I needed to talk about, Sylvester.
Yes, that is a great presentation. At least now we know what we need to do and what we don't need to do, and when not to do something, because some of us may run into those units because they have heard of Ebola, but there is a time you don't need to take some actions. So at this point, thank you so much, team. So the biggest question is, are we ready as a country, or are we ready as a hospital to receive an Ebola patient? Or when we receive the patient is when now we'll be asking ourselves, where do we go to? Or you start telling the patient, can you move the other side? Which will basically cause a lot of panic and tension, and basically will scare off our patients. So we need to get a better approach to this so that now we know what we can do. So at this juncture, I'm going to start taking questions. I know we have a lot of questions. We're going to take them within the next 10 to 20 minutes. And during that time, basically, I'll display a certain CPD points code. So if you had registered, you will have a CPD point. If you have not registered, kindly register so that your name can be put in the system for the CPD point. Kindly. So at this juncture, I'm going to ask the questions. I believe, Mr. Were, you're still here. I can see Professor Njau is still around. Mr. Were, can you kindly confirm?
Kama hizo mara 2, 3, 4 tumeiva.
Yes, I'm there.
Okay, thank you. I don't know whether it's Mr. Charles or Miss Charles or Mrs. Charles. Kindly. Kindly. Okay. So one of the question is going to Professor Njau. You have the first question. At what stage of incubation period is coagulopathy witnessed? At what stage of incubation do we witness coagulopathy? Prof?
All right. You want me to answer it immediately?
Yes. Just answer as we proceed.
Yes, thank you very much. I will say that actually, when you're beginning to see fever, which will be among the earliest, and last time I did intimate that actually patients with Ebola also show as an early sign sore throat or upper respiratory infection before they start showing all other systemic, then we are out of incubation period, because that's onset. It's clinical onset. Now, progressingly, there is a sequence they say 4 days, 4 more days. That is, immediately you start getting the symptoms. You get to another 4 days of severe illness. It becomes no severe illness. And then another 4 days, you begin to have hemorrhaging. If you do not arrest within that time frame, then it looks like the patient gets to, we are on the losing end. More often than not, if you remember, yes, Were did handle quite a bit of case management, but remember that it is not only there are routines that you must do. You must prevent super infection, because the immune system, there is actually lymphocytic apoptosis, whereby patients begin to lose protective capacity. So we cover them with an antibiotic preferably oral, not injector, because you will increase hemorrhaging, and also keep monitoring and correcting electrolyte imbalance, otherwise patient's gonna die. And I said it's a nursing duty to make sure that the patient does not get hypoglycemic, because quite a bit of some systems will fail. Dehydration, hypoglycemia, that has to be sorted out. But the moment you start seeing a clinical sign, it's no longer incubation, that's onset of illness. Thank you.
Thank you so much, Prof. Thank you so much. The next question here is, can HIV patients survive Ebola? Is HIV an independent risk factor for the fatality? So back to you, Prof.
Yes, last time I did say that extremities of age and all the immune suppressant conditions, including coexisting, already existing chronic diseases, increase chances of death. Take an example, a person who has polyuria because they are diabetic, more often than not, their electrolytes are never in the optimal level. Sometimes they will be either excessive or on the list. If they start having multiple organ dysfunction syndrome that also Chris and Were did mention, then most likely you triple, and then they start dying of many other complications. They will get arrhythmia that can even result in a heart attack. Some of them will go into coma that may be very difficult to reverse, and the petechial hemorrhages can be much more severe in patients who do not have various, they have a fragile endothelium of the tunica intima of the blood vessels. So those are all risk factors. So they will increase. So when you have somebody that is also HIV, again, they are at greater risk of other infections. Then they develop a cytokine storm, invariably go into multiple organ dysfunction syndrome. So their death rate is very high. Thanks.
Thank you so much. There is someone who is asking a question here. The answer is yes, but maybe Prof, you can just add something. So he is asking, are strains named as per the initial incident origin locations? The answer is yes, but Prof, also you can add something on it.
Previously, if you all remember, diseases were named by the names of the scientists that discovered. That's why you have TB called Koch's disease, because it was identified by Robert Koch. But also Koch is the one who identified Vibrio cholera. So then they kind of migrated from that to naming it from where it was found. Marburg, the cousin of Ebola, was formerly called green monkey virus disease. But then, after the patient that was in Nairobi in the 70s, there was a white man, and the nurse and the doctor that were taking care of them died. But however, the lady who the white man had visited was having good time visiting Mount Elgon, was found not to be having anything because she had lived in that forest and had gotten small exposure and was immune. So it was named Marburg, which is a city in Germany. So that's why it's called Marburg virus disease. So currently, they're called by the name of where it was first detected. And Ebola is the name of the river in Kikwit City in DRC. So it was called by the name of Ebola River. There was another hemorrhagic fever that was found for patient was referred from Zambia, Lusaka, to Joburg, and it was called Lujo virus, which was Lusaka Joburg. So they call them like that. Thanks.
Wow. Thank you so much. Thank you so much. That is a nomenclature, naming of organisms. Okay, so there is another question here. I think Mr. Christopher, you really tackled about it concerning the incident management. So you can just respond to it. What is the reporting pathway and escalation process once a suspected case is identified? So you had talked about it, but you can just say something about it still.
So the reporting pathway ideally should be, we assume the patient will walking into the facility or be brought by relatives, the person at the peripheral area, if they think there is what we call case definition, we have the what we call the suspect, probable, and confirmed. So in the periphery there, it will be mostly at the suspect level, where there might be epidemiological link. Somebody who has traveled to the endemic areas or the area where the epicenter of the disease, then or must have come into contact with somebody who has actually been in contact with some people with the disease. That is the suspect. And that is actually where the person can come into the facility. And they always come to the facility with some symptoms, maybe fever, general malaise, and all that. If you think that this fits the case definition of a suspected case, what do you need to do? In our setup, actually what it should be, you call that number. There's a hot number for the Ministry of Health. And we assume that the person who is supposed to be manning that center is a trained respondent or is a trained incident commander. When they receive that call, they are the ones who are supposed to coordinate. The government at that level should have a designated ambulance system, which can maybe St. John ambulance and all that. And in that St. John ambulance, there must be people who are able to handle a suspected case. And even before that, that person at the headquarters should tell the person who identified, the nurse or the doctor who identified the patient, that please isolate this patient as we come and do further tests. That is the first call. Actually, the first call should be to the ministry. And the ministry is supposed to respond by containing that suspect at that area. I remember I said the first day, a principle of managing an endemic or an emergency like that, you manage it as close as possible to where it happened, because we don't want to spread it around. So once the patient is isolated or the person is isolated, if there is an isolation facility within that area, the patient should be moved there with appropriate ambulance, appropriate vehicle, and all that. And in that facility, they remain under observation, not necessarily as Ebola patient, but as a suspected case. After 21 days, usually we take the sample 72 hours after the onset of the symptoms. That is when you are likely to find the virus, that if the infection is actually valid. Otherwise, if you do it immediately, it may turn out to be false negative. You allow the patient to go home, and then you risk spreading it if the patient was actually infected. So after the test is done, after 21 days, if it is negative, the patient is discharged and joined the community. If the test is done and it is indeed positive, that is when escalation happens. That becomes now a confirmed case. Now that is when public health will get into contact tracing and all that. So the protocol should be called the MOH, and the person at the MOH is supposed to know what they need to do, 1, 2, 3 to the end. They are supposed to have a checklist of what to do if this is a suspect, if this is a probable case, or if it is a confirmed case. They also have a protocol. They should have a checklist. You use a checklist so that there is no way of making an error. So that is what should happen at the national. That is actually the system of reporting an incident of Ebola, which should be in place. And that one should be replicated in every hospital, so that if you are in Jaramogi Oginga Odinga Hospital, you should have that protocol. If a patient walks in, just inform the local incident commander, is supposed to be the senior most person in that hospital, maybe the director, maybe the senior director clinical services, who should also initiate the same method of saying, now this patient isolate. They send an expert, usually from an infectious disease unit, and IPC people to make sure that the isolation has been done correctly. Then the management starts. That is, if it is in the wet phase, that is when we need the full PPE and all that. And when we do the test, if it is either way, if it is positive, we continue the management. If it is negative, we can allow the patient after 21 days of observation to go back to the community. And as Prof said, this is very important. We lose patients not because of Ebola. We lose patients because of dehydration, electrolyte imbalance, and neglect because of the fear. Right now, when we talk to you like this, we are equipping you so that you can be able to manage a case comfortably without even having any worries in this world. Thank you, Sylvester.
Thank you so much. So your session actually has covered some of the points and basically has raised another concern. So basically, if you can just talk about the confirmed, probable, and suspected, the case definition, so that now we can be, the team can be aware of what are we talking about.
Okay. We have the suspected case definition of Ebola. Suspected case definition is any person who presents with symptoms like fever, general body weakness, and headache, sore throat, and all that, plus epidemiological link. They must have traveled to that area of DRC or Uganda, or they must have come into contact with somebody who was suspected to be having suspected to be having Ebola. That is what we call a suspect. We have a probable case. They should have all the above signs, and they have been in contact with an Ebola patient, in contact. That is a probable case. When you do the test, those are guys who are likely to turn positive. That is a probable case definition. All the symptoms plus having been into contact with somebody with Ebola. Maybe they performed a burial, maybe they were in the same room, they were using the same amenities in the house and all that. That is a probable case. Then we have the confirmed case. We should have all the symptoms above plus a laboratory confirmed test to say that this is Ebola. So those are the three distinct case definitions. And remember, case definition changes. If Ebola moves to Kenya, the suspected case will no longer be a person who has traveled to DRC. It will be a person who has been in Busia. If the first case is in Busia, or if the first case is in Kiambu, it will be a person with these symptoms and must have traveled to Kiambu in the last 1 week. That is, it keeps changing. So that is how what working case definition happens. Thank you, Sylvester.
Thank you so much. So, Prof,
I just want to make a rider. Hello, Sylvester. Let me make a little rider on what Christopher has defined. He's defined it correctly and very well. But for probable, you say with suspected or confirmed contact. You may not completely know, but as an epidemiologist, you may become suspicious and suspect there had been contact. For instance, somebody is said to have been in that house. They switch dates and times for when they may have left and when another case was identified. That is a suspected contact. You will put them as probable because of the seriousness of the Ebola situation, and people may be trying to evade and put you in trouble. If you remember that in the last presentation, I clarified that the lady who was sleeping with the mother who died in Masindi after she had been discharged from Gulu Hospital was found to have IgM positive to Ebola. The guy who rode the bicycle as they put the lady who died in the hospital or going to Masindi Hospital was also positive. So you cannot kind of define what would this man had in common, and even the lady who had never touched that patient, but then they were suspected contact, and surely they were because they had the IgM positive. The dosage was slow, so they never quite developed the disease because it was not an infective dose. So you say a suspected or confirmed contact. The other person that you consider to be probable is somebody with known contact and then is found dead with no other information, is a probable Ebola death. Thank you.
Thank you so much, Prof. At that point, don't go away. Still on the issue of case definitions. So, can you also confirm if we normally have the discarded case? and also talk about when after recovery, the studies that we have seen going around is that a person who has recovered, maybe the virus may not be in the blood. They have tested negative in the blood, but in the semen, sweat, urine, the breast milk, they still have the virus and they can do a reinfection later. They can still transmit, but on a lower level. So what do you comment on that in regards to the recovery and also the body fluids later having the virus?
It's now mandatory because after the West Africa outbreak, it was found there was this man who had EBOLA and recovered, but then he had taken some time when the wife actually picked up the infection and had to clear from the isolation unit. Then he refused that he should abstain or use a condom, and said, somebody I'm married with my own money. So he ended up dying and left the wife, of course, for other people who were patient to wait. But he actually died because, and that is what confirmed that there are Ebola viruses that also tarry in women's genital area. They're also not supposed to breastfeed because in the lymph glands are known to be some of the places the virus harbors. So as you have put it rightly, those people will be advised on hygiene and keep changing and washing clothes and disinfecting until they are confirmed that they're no longer having a potential to discharge. And the biggest areas of concentration are basically the genitals, because sometimes when you sweat, it's not from the lymph gland, it is from the sweat glands on the skin, so they may not have much direct contact. Unless there's a change in clinical presentation, patient begins to feel ill and runs a fever, then in that case, you change the story. It's like a recrudescence of the infection.
Thank you so much. Thank you so much, Prof. You hear that the team, you can now appreciate why we have this session. And also we are joined by Dr. Abdi, the board chair of NCK. So you will give you a chance also to give our award before we end this session. So just keep in touch. Keep following us. We are going to give you our space to give us award. So I think at that point, we have answered the question for Naomi that was asking about in malaria endemic regions, what will point the teams away from malaria and Ebola and to Ebola area. There's a specific sign and symptoms or rather than bleeding. So I think we have answered that. Another question is here. So another point is here. Ebola being a global disaster. WHO and ISSC guidelines emphasizes integrating MHPSS into all stages of outbreak management. I was just wondering what guidelines are in place and MHPSS resources for PFA, eventual trauma, loss, stigma, and counseling interventions. So I think, Prof, you are in a position to respond to this because you have worked with the policy guidelines and also in the works of Ebola for a very long time. So I think you can talk about this one, about the guidelines that are there.
Yes, my comment is going to be a little bit outdated because I don't know whether they've undergone any recent revision. But yes, it's true. We put in place case management guidelines and also psychosocial and mental health support, mental health and psychosocial support to the victims and also their immediate relations because of the stigma. Especially like what the experience that was found from the Gulu Masindi outbreak is that people who recovered, when they arrived home, people either ran away from them or just removed them from their home because they was being said, you've come to kill us. So there is a lot of need for that to do mental health and psychosocial support for persons that recover. And the process should be that this person, you actually don't wait until they are completely ready to be discharged. You start calling the relatives to show them the journey and how they've recovered and confirm that they really are not at any risk. But also, then the risk about which is relatively very intimate, to tell them that sexual a process can sustain transmission up to 3 months after the people have complete remission from active Ebola infection. Thank you, sir.
Thank you so much. Chris, I'm bringing you back on this. How long does the virus stay in the surfaces? First question. Then the second question is asking about the persons who have worked in during the COVID-19. Are they able to work in the isolation areas currently, or do they require more training? Christopher, are you there?
Oh, thank you, Sylvester. How long does Ebola virus survive on the surface? I think Prof could have handled that better. I think he's very conversant with Ebola. Maybe you can direct that to Prof.
Okay, Prof, you can pick it. Yes. Now I will reiterate what I said a little earlier. We are taking ourselves for a ride, which is not fair, because I will talk about COVID. COVID was lasting up to 21 days on currency notes, was lasting up to 9 days on spectacles, was spending several hours varying on various surfaces. Well, I can't remember all of them, but there was evidence that was picked up and written by some, I don't remember which university, I think Nexford or something in the UK. They did quite a bit and they found it was lasting that. Now we do not even know the current virus in terms of its molecular characterization or genomic sequencing. So those are the issues that we need to be learning before we run to think, all we need is an American isolation, quarantine isolation facility. And I also want to mention, because I know Chris covered this very well, I want to reiterate that even where you have an integrated IDU, infectious disease unit, quarantine patients are not mixed together with confirmed, because an in quarantine patient, they don't share ablution facilities, they don't share toilets, bathrooms, and they also make sure that all water does not have a flow back, because the contaminated water could carry virus and infect people. So that if they have to be discharged, then they are released completely very well, safely. But if they have been confirmed or their dead bodies are arising, then they are treated as very infectious material. The water that flows, the effluent water, waste must be treated before final destruction, because it's considered to be infectious, including, even if you have a very expensive patient monitor, you will destroy it at the end of the day. If there was a laptop or other computer, it will be destroyed, but after being decontaminated effectively. So that is the rule of the thumb. And remember, I also reiterated that where you bury Ebola bodies, that's why people are not allowed to take them home. It must be supervised for up to 15 years after the last burial. Thank you.
Thank you so much. Mr. Kibot, you can come in with if the team that worked during COVID are able to work for the Ebola, and also what is the criteria for staffing for selecting the team that can work in the Ebola team, as we wind up with the questions.
So thank you, Sylvester. I think in theory, yes, because at least the people who worked with Ebola in the infectious diseases unit still have the skills of donning and doffing. They still have standard precautions up their sleeves. They are still conscious about how to make sure that there is no transmission from one patient to the other, patient to staff, or staff to patient. So in theory, yes, with a rider, they need to be retrained, because that was a different disease. This is another disease. They just need to be retrained a bit. What we can say is, at least we have a stock of people who can start us off with managing the Ebola virus disease. So that it is true. That can work. Thank you.
Thank you so much, Chris. Ben has given his input, and actually we have covered everything that he has also talked about. Ben from DRC, You're working in DRC under UN. We appreciate you and continue the great work that you're doing there. So you've really talked about what we have talked about. I think that was the last question that we have not tackled. I've seen so many questions talking about the quarantine center.
Sorry, one question. Concern about the Ebola vaccine. If the Prof can talk about it.
Okay. Prof, you had talked about this, but you can just amplify.
I just want to say that we only have an effective the vaccine against Ebola of this Sudan strain. Thai and Reston have not been prioritized because they literally are not very lethal. Budi Bugio, we do not have a vaccine as yet. My comment was, if we are in the dark about the genomic sequencing of the current virus and compare it with what was there in 2007, the first Budi Bugio outbreak, then we cannot be able to comment effectively, and therefore that may affect how a country makes a decision after seeing what the nanotechnology vaccines of COVID-19 did to the world. 40% of all females, of fecund females, women of reproductive age, had their menses disorganized because of the nanotechnology that was used. And I also mentioned about the guy who had a lot of nano particles surrounding critical body organs in Germany. A postmortem revealed that. And we also know quite a bit of people who just received a jab and collapsed and whatever, a couple of these things. So we need that kind of information is very critical, and it would be an insult to nurses if you drag them without telling them these are the situations, and people should be given the opportunity to choose whether they want to take a vaccine or not, particularly if it's made of a platform like the nanotechnology that has not previously been very common with vaccine, and we've already seen quite a bit. We need to be told if it's got to be a nanotechnology, what improvements have been done over the COVID vaccine that had disaster. So I think that's my position. For now, I will not say I wouldn't recommend, because I know there was quite a bit of issues about how we introduced the vaccine, how the post-deployment surveillance was carried out, and the many challenges that nobody could sort out because it was given to people who did not know much about vaccinology. Thank you.
Thank you so much. Thank you so much. Thank you so much, Prof, for that. So I've seen a lot of questions concerning the Ebola facility in Laikipia being raised. I'll request Christopher to respond to that. I don't want to talk to that because I don't have the it's called state what? State defense or state mechanism. So Christopher, you'll respond to that, but I believe that case is still in court. So it's always being talked. Whatever is still in court is always not advisable to be talked about. But Christopher, you can talk about something about it. You can just mention something.
Thank you, Sylvester. So maybe I'm going to talk about it as a public health officer and at the same time as an epidemiologist. That quarantine facility is okay according to the public health practice. What is happening is the misinformation being bandied around by people. So actually, if we get away from the real misinformation and get into the real issue, that is the best practice for a disease like Ebola. Remember that quarantine facility was not supposed to be for the patients. It is supposed to be for people who are thought to have been in the endemic zone. They are flown into that area, observed for 21 days. If they are okay, and after two tests, they are allowed to intermingle with the community. So that facility, politics aside, it is a very good facility to have in a country. So the misinformation which is out there is what is disturbing, because you hear people saying that we are bringing Ebola patients from DRC to treat in Kenya, which is not true. It is just a quarantine facility. Let me put it this way. If we happen to have 2 patients from Uganda crossing into Kenya, it will be in our interest to set up a quarantine facility at close to the border, Busia, so that they come there, they stay there for 21 days. If they are cleared, they can come back to Nairobi or Nyeri or wherever. So that is a protective measure which should be lauded. It's not a bad measure. We just need, the government is actually not doing justice to this debate by not coming out clearly why this facility should be there. So I think I can end there. I don't want to talk too much about it because it is something before the court. Thanks.
Thank you so much. Thank you so much, Chris. So at this juncture, I'll just request final comments. Chris, we can start with you. Your final comment. Then we go to Were. Then we finish with Prof. Then we request the other guests to also to give us their input. Thank you.
Thank you, Sylvester. So my final comment is Ebola is with us, and so will be Marburg virus disease, and maybe another flu-like disease might come around. What I am saying is, as nurses, as healthcare workers, as frontline workers, we should always be equipped with information so that we are the ones who are in society. Let us be well informed and let us be well prepared for any eventuality. And the people up there, the Ministry of Health, can listen to us better if we are speaking in one coherent voice of managing Ebola and being given the correct materials that we need to manage Ebola. Lastly, I need to tell you that Ebola transmission is contact, so we don't need to have a lot of fear. Unlike COVID, Ebola is easier to manage because it is contact. You need to have to come into close contact with the person who is suffering from Ebola at the wet stage, not the dry phase. So let us avoid the fear and manage our brothers and sisters when they get sick. It could be your family member. How do you want them to be handled? You need them to be saved, isn't it? So let us not have the fear. And to remove that fear is doing as many as trainings like these ones as possible. Thank you very much.
Thank you so much, Mr. Were.
Yes, thank you once again, Sylvester and the audience. One thing I want to say is just to encourage the healthcare workers or the health personnel that what is key in this in managing the outbreak is having knowledge on IPC, and so that one calls on the policy or the decision makers that the healthcare personnel need to be equipped with proper training and also proper medical supplies that would be needed to help in preventing and also managing the infection when it occurs. Then one thing that I also want to say is that the health personnel just need to insist on getting proper information, and that proper information can only be achieved when you get training from the right professionals, and then again building confidence. Once you are trained and you build, and then that confidence is built in you with good motivation, then we will always be good to go, can manage any situation, even if it's not Ebola. Yes, that's what I have to make.
Thank you so much, Mr. Dan. Thank you so much for the great work you're doing. I'll give Prof. Joseph to give a closing remark.
Thank you very much, sir. This has been another very successful webinar, and I think quite a bit of people have learned. I just want to mention that it is evident we have gaps in terms of the available material that nurses can reference when they're called to take care of these patients. I would wish to urge the Directorate of Nursing, the Nursing Council, the regulator, and possibly some academia guys to come together, and they can call upon people with some experience in this area to help put simple, very, very simple and small, short material for this, including when Chris was presenting on a PPE donning and doffing, we don't have very good videos. I think we need to get Kenyan nurses do those videos so that at least we can be able to spread it in through WhatsApp to nursing groups, and then every hospital should be able to have a TV screen where the people can keep and discuss. So that is where we'll entrench these things. Case management, Where did very well. Christopher made a ride on, and I also used the pathophysiology of Ebola to identify key issues. And this is the time, particularly Nursing Council and the Director of Nursing would begin to entrench and strengthen nurse-led care. And the basis of nurse-led care is applying the pathophysiology of a disease. I remember telling you earlier, the nurse treats pathophysiology, the doctor treats pathology. These are my closing remarks. I wish you all very well. God bless you. You're great and I love you all.
Thank you so much, Prof. Thank you so much, Prof. Thank you so much, Mr. Christopher Kibot. So thank you so much, Mr. Dan Were. At this juncture, I would like to request, we had a Ministry of Health representative in, but I can't see her. We were supposed to have a director nursing services from the Ministry of Health. I'm not seeing her around. At this juncture, I'm going to give opportunity to see to the NCK board chair, Dr. Abdi, to give a remark so that as we close this session. Dr. Abdi, please kindly give your remarks.
Good evening, colleagues. Sorry, it is a bit too late for some of the people, but I think it wants to be awake for this. My name is Dr. Dabar Abdi. Can you hear me well?
Yes, you loud and clear.
Okay, thank you. First of all, I would like to sincerely appreciate our presenters. Wonderful presentations from Prof and other colleagues. And mine is to just encourage people. We are not in the old times. Everything is available within our fingertips. And I think I don't want to praise myself, but I started the first office for WHO out of Nairobi in 2006, and served as an emergency response coordinator. And of course, I'm a trained emergency response person in what do you call it, worked in Kenya and Eritrea. And one of the, of course, I think the worst type of disease by then that we saw was the Rift Valley fever of 2007, 2006, which actually happened in Kenya. And some of these issues really were the same. First of all, I would like us to Google WHO and other agencies that CDC that publish books on communicable diseases, this emerging and re-emerging. I am sure that now it has been revised, but this communicable disease control in emergencies, a field manual by WHO, which is a very good book. It's old a little bit, but now there's a revised one, and the others which you can get online are very good for prevention and control of communicable diseases. And when we are taking care of, when we have this, in fact, more often than not, the first, and I say, I would also insist, and this is what our public officer, that person who was explaining, said, when you are dealing with such diseases, first and foremost, priorities, can you take care of yourself? Because if you don't take care of yourself, if you don't gown properly, then you are risking your life, and you are risking the lives of the patients and also other colleagues. So it's very, very important that first you get yourself well taken care of, and he has really insisted how you remove and put on your PPEs. And this is really to clearly indicate that you must take care of yourself. And only when you take care of yourself, then you can able to take care of the patient and other colleagues who you are working with. And of course, your next of kin whom you'll be able to meet. That's point number one. Point number two, as I mentioned, there are a lot of books online, very, very more recent. The Ebola team that went to 2017 in West Africa, some of them with us here. So you have gotten quite a lot of information from Prof and others. Please Google and get some of these books. They're free online and update yourself every time. Thirdly, I would like to encourage very much our nurses and also students. I'm very happy to see some of my students because I sent the links to several of them. Several of my students actually, although now they have left, were in this forum. We need this as lecturers and as educators to alert and inform our students so they can be able to be part of this type of seminars and the lectures. And also the other seminars that come up from KSHO, that is Kenya, what do you call, the cancer group, and then also Nairobi University, and then KNH, very wonderful seminars, which almost happen daily. We need to encourage our students to be in touch with this because it really gives them updated information of really what's happening. And I sincerely appreciate my younger brother, Otieno, who has really made a lot of improvement, and this is what we want each and everyone. Prof has been, I think he has really lived his own life in this area, and we need to see, I don't know whether I've missed it, but we need to see your publication from the last point of view. How do you handle the communicable disease, and particularly the disease surveillance and the other things that you have been dealing with the last almost 30 years? Clearly, I'm sure, because he was just I think 1 or 2 years behind me, if I'm not wrong, in undergraduate programs. So with those many remarks, you must continue to educate yourself. If you keep on those old things, then you will be the first victim of infecting yourself, leave alone assisting anybody, and you will be causing more casualties. Educate yourself, keep abreast, and attend the various webinars and seminars that take place. And please, let's also join the groups that take place, because it is here when we are able to update ourselves and we are looking at, or maybe hearing some of these presentations, we can able to assist ourselves. I will keep that one there. Now let me talk like a nursing council chairperson. And I always say, and I want to repeat it again, there's no nursing council without you. If you are not there, nursing council will not be there. Number one. Number two, you will not exist if there is no nursing council. Because if there is no council to register you, to regulate you, to do each and everything, then you will have no one. You will become a traditional bad attendant or whatever. So nursing council is you and you are nursing council. Keep the image and the professional image and the what we call visibility of high standard. You have seen recently, sometimes a few months ago, and I always keep on repeating, there was an article, midwives, you are puncturing our wombs with your long nails. Which nails? Not the natural ones anymore, artificial nails. Believe me, I went just about not 4 months, even less than 4 months, to a huge, very respectable hospital in the city of Nairobi. An ICU patient, which I had my ICU patient, and the patient that was taken care of. Please mute whoever is that. Ben, please, can you mute kindly? Ben, kindly, thank you. Who was taking care of my patient? The nurse who was taking my patient in a very highly respectable private hospital was wearing artificial nails. Can you imagine? Not natural. So these patients were saying, midwives, you are puncturing our wombs with your long nails when you are doing VE, which you don't even explain to us why you are doing and how you are doing. This is where we lose. Tomorrow, when we want to go to the on the street to cry for our rights, if you are good to the public, if you are good to your employer, because the patients and the community are our employers, they will support us and will talk for us instead of us talking about our own problems. But if you become no whatever, then you will find out there's something wrong. I conducted a community health activity in an area, and what we realized, those mothers were attending the antenatal clinics very well. But the point, the time it comes for delivering, they go to the traditional birth attendants, paying double what, or even 3 times what they're paying at the hospital. Why? They said we are not too good to them. Did you watch the other night recently when we had the town hall with the PS Oluga? There's a mother who cried, and many of us actually start becoming emotional of how she was mistreated according to her, and she lost her baby. So colleagues, let's be kind to our patients, because they are those who employ us, and nobody would like to come to a hospital. And I always tell my students and my friends, when you see a patient, take that patient as yourself, take that patient as your father, take that patient as your brother, take that patient as your son, your daughter, and you will feel for her or for him. I think I've talked too much. Let's wrap. And last one, and I want this to be heard by everybody. Professor Wanjau, why with his knowledge, not able to head the Department of Communicable Disease or Disease Surveillance in the Minister of Health? We will have to be visible, we will have to fight, and these are some of the issues which I want to see, that nurses who have done their undergraduate Bachelor of Science, have done their masters in epidemiology and other communicable diseases expertise, have done even their PhD, but they cannot lead. Only one profession in the department, and I've told that, and I will keep on telling that even in every forum, whenever I go. The Minister of Health cannot be led by only doctors. No, we have enough expertise. If the Republic of USA, United States of America, the most powerful country, is led by a nurse, recently, you know, a few years ago, the head of the whole of that institution was a nurse. Why are we not able to lead? Professor Wanjau is not able to lead the disease surveillance and whatever. This is where we want to come out of it. And for us to do, we must, somebody has mentioned, we must work. Why are the clinical officers who have got similar qualifications not able to lead that? We have clinical officers who have got Bachelor of Science, they have done the expertise, they are doing everything. So why are they not able to lead that? Public health officers, similar. So this is where we want. This is where we want. We are no longer going to be outside the periphery. We will sit at that table where decisions are made. And I would like also other non-medical doctors or whatever to be part of us, so that this we can able to fight. We're not going to be for nothing, but we say we have the necessary qualification and expertise also to lead in this area. And that is what I want. But finally, let's work teamwork. You cannot do without a doctor. You cannot do without the physiotherapist. You cannot do without the nutritionist. You cannot do without the lab guy. We're interdependent. If the lab guy does not diagnose and they tell you this is a Ebola case, they're all gone. So let's embrace that interdisciplinary and what you call a multidisciplinary approach, and we take care of our patients. I'm sorry I have taken too much time, but I think it deserves to remind you. Thank you so much, and God bless you.
Thank you so much. Thank you so much, Dr. Abdi. I really appreciate your fight for nursing, and soon we'll be knocking your doors so that we can discuss on some of the things that we feel nursing should be, the direction nursing should be taking. So I've just received apology from Dr. Winja, who was dispatched for a work in another place actually, and she's just landing right now, so she's not able to be part of us. But we really okay. So she's able to say hi. So she's there. So kindly, Doc. Dr. Winja? Just a minute. Yes, so Doc is there. So as Doc is getting in, I would really like to appreciate the team that are here. I'll appreciate the CDC US. I saw a representative in. I say thank you so much. I also saw AMREF in. I also saw MSF in. Also different representatives in. So thank you so much for being part of this, and we really, really appreciate you. Daktari, are you in? Dr. Winja?
How are you? And I'm so
Thank
sorry.
you so much, Director. Welcome.
I'm really, really sorry. I could not make it. I was dispatched urgently to come to Mombasa. Just arrived a few minutes ago. In fact, I was even in the office at work. I didn't know I was to come. So I really have to apologize. I'm so sorry, but we are all together. Thanks for the able hands. I can see Njau Joseph there, my classmate Kitambo Sana, somewhere in one of the classes. And I think all went on well. And I'm so grateful that we are following the trends that are happening currently, especially on Ebola. And let us be keen on everything because we are the frontliners and we really have to take it head on. So I'm so happy that such things are coming up. And I really want to encourage you to continue doing so. You never know what will happen, but it's good to get ready and prepare each one of us to understand what is ahead of us. So thank you very much for the very good, wonderful presentation, though I didn't hear. I've just reached the room right now, and then I said it's good. I just say hi, hata kama sikuongea chochote, and I'm so sorry. Thank you so much.
Thank you so much, Dr. Thank you so much, and we'll visit you also so that you can give us the good things that you have in your office very soon. Thank you so much.
Yes, we have the strategic plan you can come and take next week.
Okay.
I printed around 900 of them for the counties. You can come and take the National Strategic Plan for Nurses and Midwives. You can come and take, and also the career progression. You can come and take a few. I printed some copies. Thank you.
Thank you so much. Thank you so much for the great work. So at this point, kindly mute Jeremiah. Jeremy, kindly mute. Jeremy, kindly mute. So at this point, I'm closing down. I'm closing the meeting. Jeremy, kindly mute. Thank you so much. So we are closing down the meeting for today. Thank you for your participation. Thank you for attendance. Thank you so much. And at this juncture, I would like former CEO NCK, Dr. Elizabeth Oyuer. I would really like to appreciate your presence in, and also I will request you to close for us with a word of prayer. And as she unmutes her mic to close for us with a word of prayer, I'll just say that we thank Let's Talk Nursing for giving us a platform whereby we can share ideas, we can share resources that we have with the support of NCK, with the support of ministry, and with the support of other institutions. So I will just request you to register. If you have not registered, register with us. And also in near future, we'll be having several sessions that are coming. So we thank you so much, Mr. Leonard, for the session. You can say a word, and we give Dr. Elizabeth close with us with a word of prayer. So please, Leonard, kindly close with us. Close with the 2-second remark.
Thank you very much, Sylvester, for running this session. We are very happy the way you have run it. To our presenters, we are really happy, Professor Njau, Christopher, Dan Were. We are really happy. And for those people who went to West Africa the last time, we are sorry that we didn't give you time, but in case we have a next session, we'll give you enough time to also share with us. And for the participants who maybe wanted to say 1, 2, 3, maybe we didn't have enough time, but we'll consider that next time. For Let's Talk Nursing generally, we normally have our bi-weekly webinars. Today, we were supposed to have a webinar on ECG interpretation, but due to this COVID-19, we wanted to finish with Ebola, wanted to finish with Ebola first. So to the Nursing Council, Ministry of Health, associations, different associations in Kenya, we are really happy and we welcome you. We can always work together, not only in this, but in several other things that we can boost, can create better advocacy, and can also empower us. Thank you very much, Sylvester. I don't have much to say, and you are all welcome in Let's Talk Nursing. I've shared our WhatsApp link channel, but in case you want to be getting these updates daily when it comes to nursing and health generally, we do post there. And maybe in case you are not able to log in, we have also shared our WhatsApp number that you can use as well. Thank you very much.
Thank you so much, our team leader, for that. And may God bless you for the great work that you are doing. So kindly, Dr. Elizabeth, I can see you are on. Kindly close with a word of prayer.
Thank you so much, everyone. This has been wonderful, and we just want to thank God for this opportunity. Let us bow down and pray. Our Father, our God, in the mighty name of Jesus Christ, we come before you this evening with thanksgiving in our hearts. Thank you for this opportunity we have had to learn about Ebola. Thank you for helping us with such wonderful speakers. Thank you for all that we have learned today. And we know that your good book says that people perish because of lack of knowledge. Now that we have knowledge, Father, we know that our fear is going to be less. How we pray that this continues in our midst, that we continue learning so that we expand our knowledge for the betterment of your people. So we thank you this evening, even as we go to sleep, that you give us a good night's sleep. And when we wake up tomorrow fresh and able to look after our patients, Father, we will come back to you and give you praise. For those who have taught us, Father, we ask that you refresh them just as they have refreshed us. The organizers of this meeting, that Lord, you continue to direct their steps. Be with us and bless us. For this is our prayer of faith in Jesus' name. Amen and amen.
Amen. Amen. Enjoy your nights.
Amen.
Amen. Amen. Amen.
Amen.
And let's keep on.
Amen.
Thank you so much. Thank you so much.
Amen. Amen.
Amen.
Amen.
Amen.